Okay, after Dr. Tanushrini's lecture on identification of cerebral palsy using GMA, which was given by Practal, I will come to give a few principles of evaluation of conditions related with movement in children with cerebral palsy, preferably above 2 years of age. That is when the child usually starts responding or moving around. Children with cerebral palsy, they usually start off late in life, and by the time they are able to respond or they are ready to show some movements, they have already got the contracture, or they have already got the secondary impairments set in due to primary impairments. Um, GMA analysis will help you in identify children with cerebral palsy early, and early interventions can be done so that the biomechanical derangements that are secondary to primary impairments will be taken care of. So the objective of my presentation is to review effect of brain damage on musculoskeletal system, to provide you assessment framework, to give brief idea of visual gait analysis and reporting. So all of you know that cerebral palsy was coined by Freud, Dr. Freud, and it was first reported by William Little in 1843. And Winthrop M. Phelps explained it in more detail and related it with birth injuries. So the new consensus statement definition of cerebral palsy states that it's a static encephalopathy, and it's associated with cognitive, behavioral, and systemic disorders, along with disorders of perception. So let's come down to consequences which we will see in altered neurological function. It primarily affects the elasticity of muscles because the muscle has become sensitive to stretch, and there is decrease in ability of the muscle to stretch in full range of motion. So that alters the proprioception, that alters the rheological properties, and it alters the muscle growth. So this leads to contracture, and it also decreases the muscle length. So as you all know, the bone is growing faster than the muscle. The growing bone is restricted by the contracture or the spastic muscle. So the plastic bone, which is found in children, is now being affected, and there are torsional deformities, there are angulations, and there is problem with decrease in length of the bone. So this all leads to liver arm dysfunction. So liver arm dysfunction is a newly coined term. It was coined in this century, in the starting decade, and these liver arm dysfunctions can be prevented with certain liver arm dysfunctions can be prevented with early intervention. The second impairment which we see after altered neurological function is there is imbalance of muscles. So when muscles become imbalanced, mostly the biarticular muscles which become imbalanced, they usually create some stereotypical deformities, which is mostly common in children with cerebral palsy. We are quite aware of increased tone in hip flexors and adductors, and these are responsible for dislocation of hip, and it is also responsible for dysplasia of hip and increased internal rotation of femur or retained femoral anteversion. So here we have got a few examples of liver arm dysfunction. So coxa valga is example of short liver arm dysfunction, whereas crouch gait is position liver arm dysfunction. Then you have got malrotated liver arm, that is external tibial torsion. You have got flexible liver arm, that is pes valgus, and you have got subluxation and dislocation because of abnormal pivot or action point liver arm. Okay, so this liver arm dysfunction leads to distribution of deficient mechanical advantage of muscles over the segments, and they produce deficits in gait, which you all see. So because of abnormal formation of acetabulum or dysplasia of hip, there is luxation or dislocation of the hip, and there might be arthrosis. Next, come down to force couples. There are variety of force mechanisms working in the body to promote range of motion in human body. Some of them we know is reutilized in overarm abduction, um, maintaining your pelvic tilts, and you have plantar flexion knee extension couple, which was recently organized. Recently, the knowledge was compiled up in plantar flexion knee extension couple, and this term was coined somewhere around 2005 by Dr. Jill Roda. So all these examples of force couples which I have given, they are important in maintaining the posture and alignment of children with cerebral palsy. So if you look down at the picture below, you have got force couples, and if you decrease the distance of the segment from the axis of rotation, how much ever increased force you give, there will be decreased amount of movement. Okay, even after increasing the force, the movement will be less. Let's discuss force couples one by one. So all of you know that monoarticular muscles are prime movers, and biarticular muscles are the ones which are responsible for maintaining the muscle segments in place. Okay, so for example, if you think of pelvis, if you think of anterior pelvic tilt and posterior pelvic tilt, they are maintained by unison of a pair of muscles. Okay, they are working in opposite directions and they are parallel to each other. The line of action is parallel to each other. So you can take example of hamstrings and rectus abdominis, which is trying to maintain neutral pelvis and taking the weight of head, arm, and trunk over the pelvis. So your hamstrings along with rectus abdominis is able to produce posterior pelvic tilt or maintain the pelvis in neutral, and erectus spinae and your iliopsoas and iliacus and rectus femoris, they are all causing anterior pelvic tilt. So if there is imbalance of these flexors and imbalance of these prime movers and synergists, then we would be getting hyperlordosis or exaggerated lordosis, and which will precede tightness of hip flexors. So you would be seeing there are two muscles named as hamstrings 1 and hamstrings 2. I want to tell you that we have got medial hamstrings and lateral hamstrings, and portion of a hamstrings is monoarticular and a portion of hamstring is biarticular. So all these muscles are working in a different range. So gluteus maximus works in a different range, hamstrings, biceps works in a different range, and semitendinosus, semimembranosus works in a different range. So these are essentially like a guy rope, holding on to the pelvis and providing a neutral pelvis. So if the surgery is done non-judiciously over hamstrings, it will lead to exaggerated pelvic tilt, that is anterior pelvic tilt, and there will be exaggerated lordosis, which cannot be compensated or treated. So that's why nowadays hamstrings or soft tissues are not worked upon. First is the ascertainment of the contracture, and the bony segments are usually shortened. Next, we have got plantar flexion extension couple. So in short, if you have got good plantar flexors and if you have got good knee extensors, your knee extension would be complete. Okay, quadriceps is not able to extend your knee joint, nor is the plantar flexor able to extend your knee joint. But when they work in unison, you would be able to see, a complete extension. Take an example of stair climbing, and if you would have, done a mindful stair climbing, you would be able to, observe or feel that your soleus is working along with the quadriceps. Okay, in order to climb up, in order to produce a propulsive power. Okay, so this propulsive power is produced by plantar flexion knee extension couple. This plantar flexion knee extension couple also works passively. That is, if you have got tight plantar flexors, it might be able to produce genu recurvatum. So when you have got altered force couples, it leads to imbalance of muscles and usually a contracture in the most dominant tone muscle. So in closed kinetic chain exercises or in closed kinetic chain testing, we usually have a chance of reversal of the roles of the muscle. Um, in the hamstrings also becomes hip extensor in closed kinetic chain, and mostly these biarticular muscles should be treated in closed kinetic chain rather than open kinetic chain. So a normal control of plantar flexion and knee extensor is required for proximal muscles to act. So if you have got good plantar flexion knee extension couple, it will be able to produce load. That is, the child will be able to push the ground, and the proximal muscles, that is maintaining, that is the pelvis muscles and the muscles of head, arm, and trunk, they will be able to work in a proper manner. So now if we combine this lever arm dysfunction and force couple knowledge, we will be able to link factors which are, creating deficient force. Let me take this example of foot valgus. If you have got a supple foot, a valgus foot, then the plantar flexion knee extension couple is unable to work to its maximum. And this is probably the reason for crouch, because the foot is now external rotated, the foot is now in valgus. It cannot create, a strong lever, a rigid lever for push off, and the moment arm for this plantar flexion knee extension couple also reduces. So how does it exactly reduce? If you look at this diagram on the right side, and if you look at the extension force 1, you would see that the marker is placed quite far from the heel. But then when the foot is in valgus, or when the foot is supple, or the foot is externally rotated, this effective moment arm decreases. When the moment arm decreases, the torque generated by the muscle also decreases, and the person is unable to push off with a good force. And if the person is unable to push off, it will affect the other closed kinetic chain segments. So that's exactly the reason for crouch. So Dr. Tanushni has thrown light on GMA, I want to suggest that traditional neurological testing is not sensitive or specific enough. And although we should not abandon the traditional testing, we still be using newer ways of identification of cerebral palsy, and use biomechanical ways of documenting progress in cerebral palsy. So let's come down to assessment framework. This is based on International Classification of Functioning Disability and Health, and I would be only talking about the body structure. In the body function, we usually talk about gait pattern functions. In activity and participation, we talk about walking and mobility with respect to community, or with respect to community context. So let's divide this assessment framework. When we document the performance in community, we call this as participation restriction documentation. When you look at the gait and do the gait analysis, you call it you document the activity restriction, or deficits in the normal gait. And when you do body alignment examination, you are examining body structure. And when you do muscle length examination, it comes under body function. First and foremost, we should be able to document the assistance taken by the person with CP, or the individuals with cerebral palsy, if the children are walking or non-ambulatory or using wheelchair. We should use functional mobility scale, and it's an evaluative measure used between the age of 4 to 18, but you can use it after 18 years also. You should document level of assistance in 3 categories, that is 5 meters, 50 meters, and 500 meters. And you have the definitions of each ordinal category in the brochure. So you can access this functional mobility scale free of cost online. And I need not go into the details of functional mobility scale. I can just tell you that N is rated when the things do not apply, when the child is unable to cover any distance. The 1 is applied when the child is using a wheelchair. The 6 is applied when the child is running without assistance and does not use any support while climbing stairs or walking on rough surface. So this is rated in 3 conditions, that is 5, 50, and 500 meters, where 500 meters is depicted as community mobility, 50 meters as school mobility, and 5 meters as home mobility. So you should be documenting level of assistance in all three scenarios, and FMS is a good responsive tool towards orthopedic intervention. After documenting assistance, we do visual gait analysis. Here we would be seeing the walking pattern in cerebral palsy, and it also helps in classifying gait patterns in cerebral palsy. We would be able to monitor interventions, um, and we can evaluate changes over time when the child increases in height, when the child is undergoing some kind of an intervention or using some kind of an assisted device. You can see the change in the gait. And visual gait analysis can also be used to decide upon the appropriateness of orthosis. Visual gait analysis is consisting of kinematic analysis. We do not consider kinetics. We do not consider ground reaction force in analysis in two-dimensional gait patterns. Here we take a video from coronal and sagittal plane, and we usually take that video through slow motion analysis, slow motion, and we do the analysis on subphases of gait. In order to make our task simple, we have got a framework of 2D observational gait analysis, that is Edinburgh Visual Gait Score, which was given by Reed et al. From the Anderson Gait Laboratory in Edinburgh, Scotland. So this scale is a cross-sectional view of gait of child with cerebral palsy, both in swing and stance phase and in sagittal and coronal plane. Although this gait lacks many of the subphases, but still it is useful in documenting the child's overall walking pattern or the quality of walking. So before we go on to this Edinburgh Visual Gait Score, we should look at the prerequisites of normal gait. So the functions which are required in stance is stability, step length, and efficiency. And to have adequate swing, we should the segment should be or the body should be able to clear the ankle or clear the foot, and it should be efficient. That is, the terminal swing should reach without any spasticity, or it should not be held back, or it should not be decelerated. That's the efficiency, and it helps in pre-positioning of the foot. So in this COVID era, and as we are moving from hospital-based intervention to community-based intervention or tele-intervention, this scale is a boon. That is, we can ask the caregivers or the parents of children with cerebral palsy to send us a good video after giving them instructions, and we can rate these videos, and we can quantify the amount of deficit these children have. I would be just linking the patterns of the scale to produce a meaningful output which can be reported. So this is our gait cycle, and as you see, you have got the first rocker, second rocker, and the third rocker. So why I'm emphasizing on this characteristic feature of the gait is, if you have got all the three rockers right, then there is no problem with the gait. So you just need to look at 3 to 4 gait phases or gait variables, and if all of these are fine, that is first rocker, second rocker, and third rocker are fine, then most of the gait of the child with cerebral palsy is all right. That is, there is no deviation from a normal gait. So this is what we do in our clinic, and this is what we have done in our publication. We have this walkway of 9 meters where we have kept the camera in both in sagittal plane and coronal plane, and we have kept a grid for calibration, and the distance of the camera from the participant or from the patient with cerebral palsy is approximately 3 meters or beyond. So if you go nearer to the patient, that is, if the distance between the patient and the camera is less than 3 meters, you would get out of plane errors, okay, and everything will seem to be curved. And if the cameras are not aligned in 90 degrees to the walking pathway or the patient's walking path, then you might be, overestimating or overrating the angles, because that will be another error. That will be the parallax error. So here I have taken these two tables from a well-known book, Normal and Pathological Gait by Dr. Jacqueline Perry, and it tells you what kind of impairments will be affecting which subphases of the gait. So I have given here, um, the patterns of excessive ankle plantar flexion seen, and what happens if these kind of pathologies are there, which all surfaces of the gait will be affected. So if you look at the crosses means that that particular gait is affected because of that pathology. That is 30-degree contracture, 15-degree contracture, 15-degree elastic contracture. They are going to affect all the phases of the mid swing. Okay. Similarly, if you look at the knee, inadequate flexion, excessive extension, extensor thrust, excessive flexion, they are all going to affect mid stance, pre-swing, and so on. And we have got some coronal gait deviations like varus valgus, which is going to affect the loading response, pre-placement of the foot or positioning of the foot, and in turn it will affect the rockers. So in short, we should be careful about recording the rockers. If the rockers are all fine, the gait is nearly normal. So before we do rating on Edinburgh Visual Gait Score, you should place fluorescent markers on the bony landmarks. And if the person is wearing clothes, you need to expose the area. But in women, it is slightly difficult. So you can just ask them to wear a tight, slack, and then you can locate the greater trochanter, and you can place the marker. You can place a tight band which is just above the ASIS and PSIS, and I think that should be able to help us. We should be identifying the patella. We should be marking around the patellar cap, okay, or the knee cap, and we should be marking lines on the posterior of the tendo-achilis in order to quantify whether it is a varus or a valgus. So Edinburgh Visual Gait Score gives you 3 scores. 0 is considered to be normal, and 1 is considered to be moderate deviation from the normal, and 2 is considered as marked deviation or severe deviation from the normal. So in all, right and left sides, we have got 34 and 34 ratings. So we have got a total score of 68. So here, lesser the score, we have got lesser the deviation. At our lab, when the study was done, we found out minimal clinical important difference for this EVGS towards post-surgical intervention. We got 11 points as MCID at 6 months and 14 points at 12 months. That is, 11-point difference should be seen at 6 months before we can consider that the surgery is really helping or changing the gait of the child. So here is the Edinburgh Visual Gait Score, and this is the stance, the readings done in stance, and these are the readings done in swing. You can have this Edinburgh Visual Gait Score easily by Googling it. And I think American Association of Cerebral Palsy and Developmental Medicine also had got some reading material over EVGS. So when we rate video, we can do it either by phase, that is swing phase or stance phase. We can do it joint wise, whether you want to look at the hip first or knee first or ankle first, that can be done. You can look at the plane, that is if you want to do rating on the sagittal plane and then go on coronal plane, you can do that. And usually I prefer split screen analysis, that is I have got video from the frontal plane and the sagittal plane, and I stitch them together in a free software, and I do a slow motion analysis of this. So here is a chart of these 17 items of Edinburgh Visual Gait Scores. We have got seven items to be rated in ankle. We have got 4 items to be rated at the knee. We have got 2 items at hip, 2 at pelvis, and 2 at trunk. So I have given a color coding. So 1, 10, and 13, they depict initial contact. Okay. And all the oranges are mid stance, the yellow ones are terminal stance, and the blue ones are mid swing. Okay, so you have got zeros in the middle, and 1 and 2 on either side are reflecting upon the severity of the problem. So, like I told you, if you look at the rockers, that is the heel rocker, the ankle rocker, and the forefoot rocker, if they're all fine, then most of the gait is fine. So EVGS items 1, 2, and 3, they denote first and second rocker. Forefoot rocker is not visualized in this scale, but it is expected that when you are running the video, you can look at the third rocker and rate its quality. So, if you look at the contents of this scale, if you look at initial contact, these particular items which are recorded, the hip, knee, and ankle, they are telling you that it is a normal gait. So if you have got normal flexion or at hip, and if you have got normal flexion at knee, and if you have got a good heel contact, it tells that you have got normal initial contact, that is the leg is prepared to put the foot on the ground and cause a heel contact. Here you have hip flexion, knee extension, and ankle at dorsiflexion. Okay, similarly we have got certain items which depict mid stance, terminal stance, and mid swing. So all these yellow ones are marked as normal. So let's discuss the characteristic features of the deformities or the impairments which we see in the gait. So the feature we are looking at is reduced flexion at the hip. So your EVGS gait items 13, that is peak hip flexion, is able to tell you about the reduced flexion at the hip. When you look at the reduced flexion at the hip from the video, you would be marking on reduced flexion 10 to 24 or severely reduced less than 10. So what is causing this reduced flexion at the hip? If you look closely and if you rate the video more, you would be able to see that there is peak knee extension in stance, and if it has been rated as severe flexion or moderate flexion, it might be causing peak hip flexion, severe peak hip flexion. It may cause increased flexion at the hip, that is more than 45 degrees during the initial contact. Even maximal ankle dorsiflexion in stance, if it goes beyond 40 degrees, that is the dorsiflexion in mid stance goes beyond 40 degrees, it is going to produce marked hip flexion. So the feature which we see in these these items, that is item number 13, is reduced flexion at the hip and increased flexion at the hip. So increased flexion at the hip is kind of a compensation from ankle dorsiflexion and knee extension score. So the reasoning behind reduced flexion in the hip is it might be a compensation of weak hip extensors, and increased flexion in the hip might be because of contracture at the hip or contracture at the hip flexors or spasticity at hip flexors, and it can be another compensation from increased knee flexion or increased dorsiflexion. So the functional significance or the functional deficit which is being caused due to reduced flexion of the hip and increased flexion of the hip is decreased shock absorption. So you can have a little bit of pattern kind of thing after rating 2 or more children with cerebral palsy, and you would be able to make out the changes or make out the patterns from this Edinburgh Visual Gait Score. What I want to suggest is if the normal arcs of the motion at the hip, knee, and ankle are not followed, it is going to reduce fluidity of the gait, and there will be abrupt appearance of subphases. What deviations do we see at the knee? Let's see. We can see reduced flexion at the knee and increased flexion at the knee. So reduced flexion at the knee is caused by weak knee extensors, and it can also be because of knee flexion contracture or spasticity. Again, the functional deficit here is shock absorption, that is decreased shock absorption. If there is increased flexion of the knee, it might be due to compensation for the knee extensor weakness. Here you would see that the trunk is bending forwards if there is compensation for the weak knee extensors. The inadequate ankle dorsiflexion in terminal swing and inadequate knee extension in terminal swing are also responsible for increased knee flexion. Now, the functional deficit which you see with increased knee flexion is loss of the first rocker, decrease in shock absorption, and decrease in the progression of the gait. If you come down to mid stance and terminal stance, we usually see the deficit or the feature as excessive plantar flexion, early heel raise, delayed or absent heel raise. The reasons behind all these impairments is might be plantar flexor spasticity. There might be compensation for the knee extension weakness, and the child might be having apparent limb lengthening or true limb lengthening that is causing early heel rise, and you are getting a recording of early heel rise on item number 2 and reduced dorsiflexion on item number 3. Even severe hyperextension is going to affect your recording at the ankle and the heel rise. So the functional deficits we see here is disruption of the second rocker. Let's talk about what happens at the hip or what happens at the combined segment. We can see in-toeing and out-toeing, and like I told you that it is like a liver arm dysfunction. It is going to disrupt the third rocker. That is, it is not allowing the calf to produce adequate force in order to create a knee extension at terminal stance. Okay, so out-toeing is caused by weak plantar flexors. It can be because of the valgus alignment of the foot, and it can be because of the extensive tibial torsion. In-toeing, on the other hand, disrupts the forward progression, and it can cause instability, ankle sprains, and it can cause frequent falls. And it is because of internal tibial torsion, increased femoral anteversion, and varus alignment of the foot. So, like you see the contents of the Edinburgh Visual Gait Score marked here, what I want to suggest is one item can be related to other items, and this helps you in forming a pattern and identifying what is wrong with the gait. So even though you have not observed the child, examined the child and observed the child in person, you would be able to identify some impairments from the gait. Now, if you see hip internal rotation and external rotation, they are just disrupting the progression of the gait, and internal rotation at the hip is because of increased femoral anteversion, and external rotation at the hip is because of decreased femoral anteversion. But then external tibial torsion and internal tibial torsion, along with varus and valgus, is also contributing to the hip internal rotation and external rotation. If you look at the pelvic obliquity, you would see adduction deformity or abduction deformity. So abduction deformities are rarely seen, and it is because of the compensation of the length of the limb, and it just results in wide base gait. If you see adduction deformity from the frontal plane, you would see there is decreased base of support, and it is caused by adductor spasticity, weak hip abductor group, and it is a combination of hip flexion and internal rotation. So we rate it as pelvic obliquity, and the side which is being rated is marked up and down in relationship with the trunk. In pre-swing, mid-swing, and terminal swing, we see increased flexion at the knee and limited flexion at the knee. Okay, and these are the items which are, on the left hand side, I have got item number 7 and the item number 10, which is contributing to peak hip flexion. Okay, and the peak hip flexion and the knee position at the item number 10 is contributing to walking on toes. Okay, and not allowing enough dorsiflexion in the swing phase, so that is, there is no clearance of the foot. So because of limited flexion, that is, if the leg remains in extension, which is seen in stiffney gait, there is no proper foot clearance and the pre-positioning of the foot is affected. And if you look at the abductors, usually the hip abductors are fine. It's just that they do not have enough motor control. Again, when you look at increased flexion at the knee, you would be seeing that there is compensation for the hip or compensation for the ankle. And the functional deficit usually is not affecting the child's gait. So now I have tried to map how a crouch gait would look like in EVGS. So this is how a crouch gait or a jump gait will be looking like in EVGS. And this is how a hemiplegic gait will be looking like. So it takes some practice to, ascertain the correct responses to the items of this gait analysis score. And once you are proficient with it, I think you would be able to rapidly rate the videos and you would be able to give the opinion. We are using spinal alignment range of motion measure, and I won't be going into much detail about it. This is kind of a graph which comes out after we have scored the spinal alignment range of motion measure. And this is muscle length examination. And this is how we report. So if you look in the table, we have given the range which we have noted down from muscle length examination. We have got traditional MMT. We have got selective motor control of a particular muscle in question. Then I am noting down what are the impairments in the stance phase and in the swing phase. So I write after visual gait analysis, there is initial drag or reduced foot clearance and swing. Sorry, initial drag or reduced foot clearance and swing. I think I have mistakenly reversed the boxes. And I give the inference that timing is late and the motion is not controlled. Below, I am writing functional mobility score at 550 and 500, the score obtained in spinal alignment range of motion measure. And if the person is choosing one device over the other, that also I am writing and I am giving remarks. So this is a complete report which is generated after EVGS, patient examination and recording what kind of assistance the child uses. So I think this kind of reporting is beneficial for other healthcare professionals also. Once they look at this report, I think they get a hang of what is wrong with the child. So in short, I just want to tell you that instead of just looking at the phases of the gait, we should be, identifying the patterns of the gait, and we should be linking it to obvious, secondary impairments which emerge out in cerebral palsy. And in this way, we would be able to use this Edinburgh Visual Gait Score in community settings or through remote telerehabilitation. If anybody has got a doubt, you can contact me at sauman.g@smims.smu.edu.in.